Everyone. First of all, I think we all have been going through this very horrible time with the pandemic of COVID-19. In a way, we are now obviously making best of the time. Obviously, I'm working 4 days in, 4 days out, so it's my 4 days off now. So I'll be back on Friday at Heartlands. But thanks to Taya for arranging this because it keeps me busy as well to kind of prepare presentations and do other research stuff and stop me from getting rusty. So bit of background. So I work in Heartlands and Good Hope Hospital. So I'm one of the interventionalists here and I'm one of the CTO operators. I started in 2014 and started doing CTOs from 2015. We have been privileged because we had support from Professor Nakamura from Japan. So he works in New Tokyo Hospital. So I met him when I was working in Italy, because he used to come to Dr. Colombo's unit in Italy to some CTO cases, and that's how the collaboration started. And since then, I think he's been coming to our unit almost every year, and he's come sort of over 6 times and done several cases and taught us through his technique of CT angioplasty. So we have been mainly following Japanese way of doing PCI, although I will come to the hybrid as well, because we have adopted in the last 2-3 years, and we now call ourselves as best of both worlds. We have kind of took the benefit of both. So that's the background of my practice and where I'm based. If I go to the topic itself, it's not going forward yet. I think it's okay now. So, as I said to you earlier, if you have any questions in between, please pitch in and ask me. I'm very happy to keep this interactive rather than just me speaking. And obviously, I'll take any questions at the end as well. So we'll start the presentation. So as you all know, CTO angioplasty is escalating globally and not only in the UK. And that's due to the improvement in the device technologies, thanks to you all who are, you're doing a great job by distributing one of the best products in the CTO angioplasty, or the leaders called Asahi products. And also there's a lot of improvement in the technique itself of the angioplasty in CTO. So all this has led to global escalation. And now probably, as you know, when I started training in intervention, there was no CTO angioplasty at all. There used to be like ad hoc CTO PCI. There were no dedicated operators. Now we have dedicated operators every hospital. So CT angioplasty is kind of escalating, and it'll continue to grow. CT angioplasty, if you go back to the, probably in early 2000, it was very restricted to certain operators in the world. They used to do procedures in their country and travel across. So we used to have a lot of Japanese operator coming and teaching us angioplasty, or just doing angioplasty rather than teaching. And now we have more operators, which is good for patients and the hospital, because if you imagine the days when we were doing left mainstem angioplasty, it was restricted only to certain operators and certain centers. And that didn't serve very well for the rest of the UK population. And then we kind of started doing left main angioplasty. Now every unit does left main angioplasty, and it is important for patients to have service locally rather than they have to travel elsewhere to have their arteries opened up. So thanks to all the innovations from the device companies and obviously the technique. So yeah, can you all see my screen? Hello?
Yes, yes.
Oh, you all say perfect, sorry. So if you go back to the traditional Japanese way, I mean, these are all the big names. So the first one on the left side is Dr. or Professor Nakamura, who's been my mentor. And then you have Dr. Kato, who invented Corsair, the one we use a lot now. And then now we've got Saito and Professor Ocha. You all know all these 4 names. So these are leaders in CT angioplasty. They started all these new techniques, reverse cart and everything. And then obviously, after a while, we then had some new techniques being invented by Professor Colombo, who had a privilege working with him. for a year in Italy, and on the other side is Craig Thompson. So they invented something called a star technique. I think most of you know what it is. Essentially, it is like your ADR, but basically no control at all. You just basically take a knuckle and just push it and hope that comes to the end of the artery in a true lumen. And you have got no control where it comes into the true lumen. You just basically knuckle and push. So this was invented kind of by Professor Colombo, and then obviously modified, and we have come to now ADR. So it started in Italy, this star technique, and that kind of gave more momentum and modification to currently what we call as a hybrid PCI, which is mainly adopted by Americans and most centers in Europe these days. Obviously, you all know the big names here: Simon Walsh, Colin Andrade, and Bill Lombardi from States. And obviously, one picture is missing, and we can't not miss this picture, and that's James Pratt. So essentially, we have come a long way from Japanese, then to the crude of star technique, and now to hybrid PCI. There are pros and cons with each of these approach. I'll tell you. So conventional CTO PCI essentially is the Japanese way of doing things, which is basically antigrade wire escalation, parallel wire, retrograde wire escalation. I'll come to all those slowly. But the good thing about Japanese technique, it's very elegant and aim to restore vessel anatomy. What I mean by that is when you do this knuckling in the arteries, you're essentially altering the architecture of the vessel. So you're making the vessel at the end like a sausage, as a huge, big ectatic segment. Whereas with the Japanese technique, it's very elegant, and it aims to restore the vessel anatomy because you're not doing much dissection in the vessel. And hence, once you complete the procedure, you don't have to come back and do optimization, because if you look at the hybrid angioplasty, if you knuckle from both sides and you deploy the stent, and the stents are in the hematoma segment, so there's a lot of hematoma behind the stents. And let's say 2 months later, when the hematoma goes away, the stents can be floating. So a lot of the time they bring back and optimize the stent, and that is not needed in Japanese way of doing CT angioplasty. As I said, no need for stent optimization. Procedures can be long and may have a longer learning curve because you have to feel the lesion, learn the parallel wire. All these techniques takes time as compared to hybrid PCI. So what are the advantages of hybrid CTO PCI? It's basically, it shortens the procedure duration. I think one of the main aim of hybrid CTO PCI is to kind of stop people doing 3-4 hours of angioplasty on a patient, putting them through a huge amount of radiation. Solution to previously untreatable lesions. So for example, in Japanese way of doing angioplasty, what we have felt is that if the vessel is heavily calcified, then it's very difficult to negotiate through these calcified lesions with even the stiffest wire we have. And that's where sometimes it takes the route of exiting the vessel and causing perforation. But with the CTO, in hybrid CTO PCI, these some of the techniques they have designed, like modifying the proximal cap and negotiating through the calcium, basically bypassing the calcium into the subintimal space, has given solutions to previously lesions which were not treatable through. And the procedure skills are because you show people how to knuckle, and once you start knuckling, it's very easy. Knuckling is not that difficult. Once you do a few cases, you'll probably know. So these are the kind of pros and cons of Japanese and hybrid CTO PCI approach. So if I go to the conventional CTO PCI, so this is basically the Japanese way of dealing with, they have antigrade wire escalation, they have parallel wire, then they have retrograde wire escalation, and then they have conventional reverse card, which I'll come to that later. Hybrid approach is basically ADR, knuckling, base, and side base. I think you all have been very familiar with this terminology, because I think you are supporting a lot of courses in the UK, which adopts hybrid approach. So we have been very lucky because as I said to you, I've been proctored mainly by me and my colleague Mike Pitt. I've been privileged to be proctored by Professor Nakamura. But having said that, we also adopt some of the hybrid approaches in certain lesions. So in a way, we are lucky that we got best of both worlds. So 70% of the time we use Japanese way of doing it, and 20 to 30% of the time we use a hybrid approach. Are you all okay so far with what I've said?
Yes, thank you.
Yes, great.
Perfect. Right. So conventional CTO PCI has got all these. So the first three are antigrade, so fine channel crossing, wire escalation, and parallel wire. Then you've got retrograde wire escalation, and a conventional reverse cart is the retrograde approach. So if I go through all of this in terms of cases, an example, you'll understand. So antigrade, we have some questions. What is antigrade angioplasty? Now, in Japanese term, there is nothing called an antigrade case or a retrograde case. They kind of switch in between. So for example, you try antigrade, you're not getting into the lumen, you made some progress, then you come retrograde, you finish the case. So Professor Nakamura's way of teaching is, look, there's something called antigrade or retrograde. You could call some cases, yes, very likely you can open this by antigrade. Some cases will need retrograde. So antigrade is basically you're wiring the CTO from the front end. So proximal to distal, you just pass a wire through the lesion. So for example, if I show you this case, so this is a case of an LAD CTO. You can appreciate there's occlusion in the LAD, as you all can see. I'm just pointing my, can you see my pointer?
Yeah, that's great.
Yeah. So essentially there's an occlusion there, and LAD fills from the right coronal artery here. So occlusion is this length, okay? So essentially antigrade is basically you taking a wire and aim to enter the true lumen after the lesion, and that's called antigrade angioplasty. It still requires a dual access, because if someone is doing an angioplasty without, someone is doing a CTO angioplasty without a dual access, it is not a good practice because you don't know where the wire goes. Now, what compels the operator to choose antigrade as the first choice? So what makes me to say, okay, let's go for antigrade for this case? It's basically the lesion morphology. So if you've got a tapered proximal cap, which means you got a way into a lesion, or if it's a very short occlusion, or if you've got a good landing zone, then probably you choose antigrade approach as a first choice or first approach. And also if you've got a bad collateral, so if you've got hardly any collaterals or very, very tiny, very wriggly collaterals, then you can't do retrograde. Then you just have to rely mainly on your antigrade techniques. So this is what I mean by tapered tip. So for example, here, you could see a way, isn't it? There's a septal which is coming right down, and there's a diagonal going up to the top. And in between those two, you see a little like a nipple where you can poke the wire. So this is called the tapered tip. Whereas you got cases like this, which is called blunt cap. So where you don't know where to poke because it's like got a very ambiguous blunt cap. And the cases like this where you really don't know where the cap is actually, because you got a lot of branches coming off. And in these cases, it's very difficult to kind of identify where the cap is and to poke. So these kind of cases makes antigrade approach unattractive. Then you have this shorter occlusion. So for example, here, the occlusion is very short. That's all a very short occlusion. So these occlusions can be negotiated easily with antigrade approach. So in these cases, if someone takes a retrograde, it's not a good choice. You can do this kind of 99% of the time, you'll be successful with an antigrade approach. And I said bad collateral channel. So for example, this patient has an occlusion of the LAD, and you could see there are collaterals from the right coronal artery into the LAD through the septal channels, but they are very, very small. And in this case, we tried using retrograde. We could not get any of the retrograde channels. Off late, I'm doing something slightly different. And it has happened in the last 5 to 6 of my retrograde cases. And I've shared this experience with other CT operators. So what I do is I put the patient on a G10 infusion. So when they come into the day case for the procedure at 8 o'clock, I start them on a very small dose of G10 infusion. So what it does is basically it swells your collaterals nicely. And since I've started doing it, all the 5 retrograde cases have been successful because I was able to enter the retrograde channel very easily because the arteries are nicely swollen because of the G10 infusion. So sometimes you have got no retrograde option. So for example, this case, a patient has an occluded LAD, that's the occlusion of LAD, and occluded right coronary is occluded. So if you want to go here, you don't have a retrograde option, because if you want to open that LAD, you have to do only antigrade, no matter how difficult that may look, but you got no choice, because here there are no collaterals to the other side, or from the other side. So now coming to the types of antigrade CTO PCI techniques. So as I said, there are mainly three from the Japanese approach. One is a fine channel tracking, then wire escalation, parallel wire, and then you have ADR, which is the hybrid CTO angioplasty. So if I show you fine channel tracking, essentially what it means is a lot of people don't call this as a CTO. They call this as just a functional occlusion, because there is a small channel connecting the proximal end to the distal end of the artery. All you have to do is access that little channel. So you just take a wire, like a slippery wire, like your Fielder XTA or XTR, and just basically traverse through the functional occlusion. So it's called fine channel crossing. So if I show you a case here, for example, this is a case of an RCA CTO. If you look very carefully, there appears to be what you call like a small channel. Then you can appreciate that, because here the vessel is filling antigradely. So there is no retrograde injection here, as you can see. And when you inject from the antigrade, it is filling, which essentially means there is probably flowing through that occlusion through a very, very fine channels, which is why it's not filling the whole artery. It's filling probably some segment after the occlusion, because it's not big enough to take a lot of contrast to fill the distal vessel. So in this case, for example, that's a Fielder XTA wire. So the Corsair. So all I'm doing is trying to find the channel, and the Fielder XTA is so good. All you need is just to kind of gently twist the wire, and it'll find the way. So here it just went forward, and then I confirmed with a dual the injection from the other side, make sure distally I'm okay. So here I was fine, and I was able to finish the procedure. This is another case of a RCA CTO. Again here, can you appreciate there's a small channel here? So if I pause it at this point here, can you see here? That's the channel. That's the right ventricular branch, and that's the channel. Can you see the channel? Anyone appreciate that?
Yes.
Yeah, we can see it.
So that is a channel which you can easily access with just a Fielder XTA wire. So that's what I did in this case. But in this case, the problem I had was, because the side branch was coming right at the occlusion, every time you push a wire, it goes into the side branch. Every time I'm trying to negotiate a Fielder XTA into that little channel, it takes the more easier one, which is the right ventricular branch. So in this case, I used this. This case was done only a month ago. I use this. Have you heard this called Sasuke, which you guys distribute a lot?
Yeah, we've heard of that.
So this was a great case, because essentially I parked the Sasuke right in at the ostium of the right ventricular branch, and I've taken the second wire, which is that Fielder XTA, and I'm just trying to poke into the lesion. And you could see here, this is a nice picture. All I'm doing is I'm just accessing the channel. Can you see that? It just crossed.
Yeah.
And then I was able to check with the other side, make sure I'm in the true lumen, and finish the procedure with a nice. So this is a great technique using these Fielder XTA wires. Unstable. Yeah, so it's a tapered tip which is designed to access these small channels, and it's also very hydrophilic. So let's come to wire escalation. So what is wire escalation? Essentially, it means, so for example, you may have a lesion where you have some fine channel to enter the body of the lesion. So like here, which you take a Fielder XTA, but then you come with the most hard part of the CTO where it's more solid, where there are no fine channels. Then you need more probably a stiffer wire which has got more meat at the tip, like Gaia or a Miracle or a Confianza. So then you take those wires and then come to the other side and connect the two and finish the case. So if I show an example, this case again was done literally before the lockdown, literally the last case of my CTO before the lockdown, before we canceled all the electives. So this patient had a stent before, and it was blocked. Obviously, it's an interest in CTO. And as you can appreciate, there is a channel. Can you see there is, so the occlusion starts probably here, but then there is a little channel into the body. After this, there are no channels. Okay, so this is a classic case where I was able to enter that with the fielder XTA, and that's the Corsair. Now, obviously, I came across a very hard lesion. So I tried with a Gaia 3, and I was stuck at that point. So there was no progression here. Every time I pushed the wire, it was knuckling or buckling because the lesion was very hard. So then I took your Confiance Pro 12, which made some progress, but you could see it, even it's kind of started making no progress. And at this point, I took the Hornet, which is the 14-gram wire from Boston Scientific. And again, that started making some progress, but kept buckling. Now I checked in the other angle, and I was right at the center of the stent. So I was happy at this position. So I decided to take your Conquest, which is a 20-gram wire, or Astato wire. And I was able to spin that wire. It needed that extra push from a stiffer wire, and it went in. At this point, it was very interesting. The problem with the Astato wire, as you know, it's a 20-gram tip wire, and if I use the Astato to do the procedure, there's always a risk of distal wire perforation because it's too sharp at the end. So what I did was I couldn't advance the Corsair because the lesion was so calcific and fibrocalcific from the intrastent occlusion. Even using an anchor balloon in the side branch, I could not spin the Corsair. So, but I had made a channel with the Astato. So what I did was I used a fielder FC wire and used that channel which I had made from the Astato to enter the distal. We'll see in a minute. And then I was able to finish the case in the end. The distal vessel doesn't look big, but it'll grow. It just occlusion had caused some spasm in the distal vessel. Sometimes you have a lesion where you can't even enter the lesion with the fielder XTA. You need something harder. So fielder XTA won't even penetrate the cap. In which case you need a stronger wire like Gaia 3 or a Confiance to enter. And we all have this Gaia 1, 2, 3. You all know this. It's a great wire. Which has got more control. Then we've got Miracle series, which is less used these days. And then we've got Confiance. So if I show, this is a case of another interesting CTO where I started off with a Gaia 2 wire, but you could see the Gaia 2 was not making any progress on the left-hand screen. Then I took a Gaia 3, which made some progress. And checking multiple angle and using a Miracle as well. So that was a Miracle wire. I was able to enter the distal. So this is a nice case of wire escalation using Gaia, start with Gaia 2, then 3, then Miracle, and we were able to finish the case. So we entered the distal true lumen. And we had a good result in the end. So far, you all okay following what I'm saying?
Yeah, it's great. Thank you.
Yeah.
Perfect.
Sandeep, when you used the Astato, how easy was that or difficult was it to control?
Well, I think the problem is you can't control these wires.
Yeah.
As it gets stiffer and stiffer, it just basically goes where it wants to go. You demonstrated in a wet model, I think, in one of our courses where you asked me to wire the Gaia and then the Confiance. You had more control over Gaia, whereas Confiance, I just went wherever it wanted to go, which is why these kind of wires needs, what I learned from Dr. Nakamura is he said, if you're taking a Confiance or anything higher, you have to do it in very, very short segments. So increment has to be a very short segment. You just can't push the wire. You just have to go like an inch by inch and checking in multiple angle, make sure that you are in the architecture, because in one angle you look that you're going in a right direction, but then if you look at the other angle, you're probably miles apart. So if you push, then you'll exit the vessel. So all he's saying is just to make a small increment and then check in multiple angles And when that part of the occlusion is over, when it's the difficult part is over, then change it to a much more friendly wire like a Gaia 3 or in field RFC like I demonstrated in that case. That's a bad thing about these wires. As they get stiffer, they're great wires to negotiate tough lesions, but once they get past that, it'll go wherever it wants to go.
The importance is to de-escalate once you've made some progress.
Yes. So essentially, if you have dealt with that difficult bit of the occlusion, and if you are now in a relatively, that is when you feel the lesion. So with the Nakamura technique, you can feel the lesion. Okay, now we have finished the heartbeat. Let's go back to the Gaia 3 or something. Or if you, let's say, if you enter the distal vessel even with these stiffer wires, make sure you exchange it to a softer wire. Don't work on these. We advise not to work on these stiffer wires because invariably the wire will go forward and it'll perforate.
So the Nakamura technique, you sort of rub your fingers together. What is that technique, and how does that allow you to feel the tip of the wire? How does that give you feedback?
Well, I think it's like a tactile feedback. I think it comes with, I mean, this is what, when he started talking this in 2015, I used to think he's mad. I mean, it's like, really? Can you feel this lesion? You know, he used to say, look, the wire is basically end of your finger. You feel the lesion through the wire. That's calcium, that's fibrous. I felt, even now, look, I'm very honest. I don't think so. I'm even like 1/3 what he can. But at least now I know there are lesions. In fact, I've shown it to my registrars and my other colleagues. Look, can you feel this is the fibrotic? You could feel it because it just feels different. Calcium feels very different. The moment calcium is like a real rock. You could feel as you're bringing back and pushing a little bit, you feel that like you're tapping a rock. That's calcium. I think it just comes by experience. I mean, he has done it for 20, 25 years, and obviously his depth and his number of cases is like phenomenal. It'll take 5-10 years to kind of even come anywhere half what he's done. But all I'm kind of saying for the other CT operators who especially were in the beginning phase of learning is that I think these techniques are great, and it takes time. This is like a 5-day cricket match, not like a T20. So you invest time and and effort. It'll come by. As I said, not all cases can be done through Japanese technique. There are cases you have to do hybrid way, but it's a nice technique to learn.
Thank you.
So next I'll go to the parallel wire. This is probably where I'll be focusing more because Dave wanted me to kind of highlight more on this. This is an elegant technique. So essentially the principle behind parallel wire is that, let's say you take one wire and you make a progress, and then you find out it has gone subintimal, not into the lumen, then essentially using that wire to redirect if you can. It's called wire redirection. If you can't redirect, the best thing is to keep that wire there, then take a second wire, use the first wire as a landmark, and then you use the second wire going either medial or lateral based on where your wire position is to enter the true lumen. So the first wire acts as a landmark and you use the second wire. Sometimes the second wire also goes subintimal. Then you take the first wire back into in a back position, then use a second wire as a landmark and then re-enter. So it's basically going in parallel. That's called parallel wire technique. So essentially it's like this, schematic. So you take a wire, it's going subintimal, then use that as a landmark, and then you enter the true lumen. So if I show you this case, so this is that taper tip short occlusion, short-ish, sort of 20-25 millimeter occlusion. So I started off with a Gaia 3 here. You could see I'm kind of heading in the right direction. Then I make a bit more progress. So again, I'm doing every small increment and checking with the retrograde injection. And here, and then I push and I clearly go subintimal. Can you appreciate? I've just gone subintimal here.
Yeah.
So I took wire back into the lumen, but I couldn't. So what I did was I took a second wire. The second wire is now behind the first wire, and using it as a landmark, I pushed a little bit more, and now you see I'm more in the vessel architecture. And then when I advance more, I'm in the true lumen. So this is parallel wire. So using a first wire as a landmark and then entering. This is a case of a circumflex CT, again, short occlusion. As you can appreciate, there's a short occlusion. It's very calcified in a post-bypass. So I started with the Gaia 3 here, clearly went subintimal. So Corsair, Gaia 3, completely out of vessel architecture. So what I did was I kept that wire and I used a second wire and second wire went the other way. So this is a case where the calcium, this is what calcium does. Calcium basically redirects your wire. Because it's so stiff, the wire will take the most easier route. Then I use the that as a landmark, and then I turned the wire more inward. And you could see here, that wire is close to the lumen, but it is still not in the lumen. It is close, but it's better than my previous position, which was this. So I'll run this again.
So can I ask a question, Sandeep?
Mm-hmm.
So the second wire that you choose, so the first one that you use as a landmark was the Gaia third.
Mm-hmm.
Do your second wire, is it always another of the same that you're using, or do you look for different properties in the second wire?
That's a good point. So if the wire has already made a progress, the first wire, which is a Gaia 3, I don't mind taking another same wire and using that as landmark. But if I'm having difficulty, like dealing with the calcium, then I go probably with the Miracle 6, 12, or Confianza 12. It all depends on how the initial lesion behaves, initial wire behaves. If it's going nicely, but just go on subintimal, all you need is to redirect that. But if you can't redirect, take another wire going in parallel, either the same wire or slightly a stiffer wire. So here, sorry.
I was just going to ask, because we don't really see, in the currents of the hybrid practice, we don't really see miracles being used that often other than to facilitate ADR.
Yeah.
So with parallel wiring, so a hydrophobic, stiffer tipped wire, what are the benefits?
So essentially, look, I've used Miracle. I don't use as much as I used to use it before. See, if let's have Gaia 3, which is your 4-gram tip wire, okay? And I've come to an interest in CTO where I'm not making any progress with the Gaia 3. And if I want to go up, the next choice obviously is your Confianza, which is 10 and 12 gram. But 4 to 10 grams, if you got an option like a Miracle, which has got 6 property, which has got better push than the Gaia, but it is not as aggressive as a Confianza, I would go for it, because I rather take something less stiffer, so that you don't want to be exiting the vessel or causing a dissection. So I use Miracle. I mean, it's a great wire actually. The only problem with Miracle is it doesn't have the control like your Gaia.
Yeah.
I think that's how the Gaia was invented, wasn't it? Because Miracle had that stiffness, but didn't have the control. That's what happens to Confianza. It doesn't have the control, but you have the stiffness. So Miracle 6 actually, it's a nice wire actually, because you can negotiate that wire like the way Gaia. It's you don't have to spin that one. You just have to turn the wire, push a little bit, because it's got more meat. It will go. So it's a nice wire. I mean, I still use it rather than say a lot of the time. What the teaching now is, okay, you take Gaia 3. If it doesn't work, then go to Confianza CP12.
Yeah.
But you can easily use Miracle in between, and you can make progress. Then you can appreciate actually this is probably the Miracle, the second wire. You could see it's very dark. I mean, one way you can see Miracle is it's very, very dark, pitch dark. So this is the second wire now. Can you see that now the second wire is a bit more close to the lumen?
Yeah.
And then I push that wire, and then I'm in the true lumen distally. So essentially using the landmark of a first wire, and then you're negotiating the other wire. And I was able to finish this case. And this is another great case of parallel wire. So this is again Gaia 3 or something. Go subintimal, clearly way out of my vessel architecture. And what I did was I tried to negotiate this wire, but it kept going into subintimal. So then I took a second wire. Can you see the second wire, which is the top wire now?
Yeah.
Yeah, you can see.
Can you see the second wire, which is the top one, which has already gone to the true lumen there, and I was able to confirm that in the PDA and able to finish the case. So this is another case of LAD occlusion. Now, a lot of the time you see when you do this case, if you show this to any operator, I've just tested in meetings, everyone say, oh, it's a great position, just push the wire, it'll be fine. So this even we felt the same at the time when I was doing this case. The wire looks so close. All you have to do is, okay, push it, it'll go into the distal LAD. But we are wrong, because if you look at the true lateral, this is a view which is underutilized in the UK. Again, all teaching from Dr. Nakamura. He uses this called true lateral. Essentially, it's in a very extreme view, so radiographers may not like it, but once you start using it, once you start showing them the benefits, they'll also appreciate it and they don't mind giving you this lateral view. So you could see the same wire in the last position, it looks so close. And if I just did a lateral, completely out of the way. So if I push this wire, it'll completely go subintimal, and if it's a sharp wire like confidence, it'll exit the vessel. So here we try to redirect the wire back into the top end of the thing. We couldn't, so we took a parallel wire. Can you see the parallel wire now there? So that's the second wire, which is now looking promising.
Yeah, you can see it.
And then we confirm that in the other view as well to make sure, you see how nicely it is now. And then you have the confidence to push that wire, and we finish the case. So this is a nice teaching case where it looks so deceivingly close, but you're not.
How many operators do you think use true lateral? Is it just your center?
Yeah, I mean, I think the true lateral is only used in probably if you're undertaking these kind of antigrade wire escalation or a parallel wire. I mean, even others you can use it. I mean, we use a lot. Me and Mike use a lot. Again, we learned from Dr. Nakamura. So it's a great, because it's a, they say you have to do a 90-degree projection between the two views. Yeah. So if you're doing a PA cranial or RAO cranial, then if you do an LAO cranial, it is not that like 90-degree difference. So best thing is to go true lateral, which gives a good 90-degree difference to say whether, are you in a right direction? Because if you are in a right direction in both the views, you're the winner. If not, you have to change the course, as I showed in the last case.
Yeah.
This is another case of a parallel wire. I think you can appreciate here, there's a circumflex CTO. So there are two views here. This is the epicaudal. So that's the occlusion of the circumflex. Okay. Circumflex CTO is the most difficult. I don't know whether you heard from other operators. Of all the CTOs, the easiest one is the RCA, then LAD, then the circumflex. The reason is circumflex is so ambiguous in terms of the course. No one knows how the vessel goes, whereas LAD and RCA, they have a predicted course. Even if the artery is occluded, if you do the multiple projections, you know where the artery should be, whereas the circumflex, it's completely ambiguous course. So this is a case when I saw it as a short occlusion, shouldn't take long for me to open this, okay? So that kind of probably an arrogance in this case. So that's the occlusion, okay? As a short occlusion, probably guy 2 or 3 will get in. So took the Corsair Pro and the Fielder XTA first. Fielder XTA did the initial bit, so took some fine channels probably. As you could see, I've entered the body of the lesion nicely with the Fielder XTA, but I was not making any more progress after this. So then I switched to Gaia 3, or Gaia 2. So here, see Gaia 2, do you all agree it's close?
Looks close.
Yeah.
It looks close, isn't it? But then you look what happens when I push it. When I push it, it is just taking the subintimal track. Anyway, so then what I did was I came back, I negotiated the wire the other side. Again, it went subintimal to the other branch. Okay, so optionally here was either go parallel wire or retrograde. So what I did was I took a parallel wire. Can you see the first wire here is subintimal. I tried to redirect this wire into both the branches, but it kept going subintimal. So if I go back to the last picture. So the first push went subintimal to the lower branch. Then second time I'm trying to renegotiate, goes into the subintimal of the other branch. So it's not taking the what I did was I took a Sasuke, which is your dual microcatheter. So the first wire which is down is the Gaia 2, and I've taken a second Gaia wire, and now I'm able to kind of redirect that into that upper branch, and I checked in the multiple views. Can you see here now? The second wire, which is now inside, not the outside wire, is more true lumen. And I was able to push. So I've kept that parallel wire, the first wire which went in subintimal, I kept it there itself, so that I was able to negotiate the second wire. You're happy to appreciate this one? I'll show you.
Yeah.
So that's the first wire. Then the Gaia 2 on the Sasuke. Checked in the multiple projection, so make sure I'm okay here. And then I got the confidence that in 2 views they look close, and then I was able to push it. And then finish the case. Here I didn't use a stent, I used a DCB, which is why it may not look great, but the patient's doing very well. This was done a year ago. So we're done with the parallel wire. I've showed you the fine channel tracking, wire escalation. ADR, I'm not going to go because I think you all know about this. Essentially, the technique behind is deliberately going subintimal, tracking through the subintimal, and trying to re-enter after the occlusion using a Stingray balloon. I think that's a cross boss, a Stingray. I'm not going to show much of this because you all have seen this in the meetings. So the conventional PCI, CTO angioplasty, so fine channel crossing, wire escalation, parallel wire, then we have a retrograde wire escalation. So essentially, when you do a retrograde case, the current teaching from the hybrid CTO PCI club is that, let's say you come to the distal end of the occlusion from the collateral. So for example, RCA. So you go through a subtle channel, subtle LID collateral, come to the distal RCA, and you now are in contact with the distal cap. Now what they do here is, they're basically the knuckle a wire, and knuckle antigradely, knuckle retrogradely, connect the two. But what we do with the retrograde wire escalation in the Japanese way of doing is, you basically taking exactly like antigrade wire escalation, you take a retrograde wire escalation, you take a Gaia 3 or a Confianza or Miracle, you're basically trying to negotiate through the occlusion. And we have been so lucky sometimes. For example, this is a case of a circumflex CTO again, okay, a short occlusion. And can you appreciate there's collaterals from the RCA? So these are all the epicardial collaterals from the RCA into the circumflex. I tried this case antigradely. I could not make any progress because it kept going subintimal. See here, that's the antigrade wire with the Gaia 3. It kept going subintimal. So I was not able to negotiate this into the distal true lumen. So I went retrograde. Now that's your CO03 wire with the caravel, which went nicely into the distal cap. Now this is interesting. When I came to the distal cap, I used a Gaia 3 to penetrate the cap and see if I could enter the proximal end of the lesion, but I was going subintimal. Can you see how the wire going into the subintimal space?
Yeah. Now
we can't do parallel wire from the retrograde because you can't put 2 wires or 2 corsairs or 2 caravel through a retrograde channel. It's impossible and it's dangerous. So if this doesn't work, then you have to negotiate the wire in a different direction. So essentially what I did was I came back and with the Confianza and poked that calcium, which was redirecting the Gaia wire. So calcium essentially was redirecting the Gaia wire into the subintimal space. So what I did was take a stiffer wire and crack that calcium. So through the calcium, I entered the proximal lesion. Can you see that here? So I didn't have to do any antigrade work here. All I had to do was retrograde wire escalation from Gaia to Confianza. And then I was able to put the guide liner and then externalize and finish the case. And this is amazing because in this case, I had entered through one of the branch and the main branch was still not connected. So I used your Sasuke on the retrograde wire and took just a fielder or a cyan blue and just entered the main vessel. And we were able to the case. So this is a nice case of a retrograde wire escalation, and we've done quite a few of them now where we track the retrograde channel, enter the body of the CTO from the behind, and you negotiate using multiple angulation and various wire, and you're in the true lumen without having to have any antigrade kit. And this is another case like that. See this RCA CTO, very blunt. You all agree it's a blunt occlusion, blunt cap. And here again, try to do antigrade. The wire kept going subintimal or a branch. So At this point, I decided to go retrograde. Can you see my antigrade wire?
Yeah.
So it's clearly subintimal. So I decided to go retrograde. That's your, I think, Sion wire on a caravel. Enter the retrograde. And here again, we could have knuckled, but we decided not to knuckle. We just negotiate. That's a Gaia 3 using the calcium. Can you see the calcium here? So that's the calcium as a vessel. So all we did was use that calcium as a landmark and came up to the proximal part of the RCA. And you see, all I'm just doing is spinning that Gaia wire. And I decided, I took two views, LAO and RAO, and I was very happy that I'm looking close. And all I did was just enter you could see that there's a Gaia 3 entering the guide. Can you see entering the guide? So essentially, there's no antigrade kit at all here. All we just did was retrograde wire escalation into the antigrade guide, and we finished the case.
Sandeep, do you use the same Gaia 3, or do you find that because that's got to do so much work that perhaps it gets the damage? Does it tolerate the whole way through the lesion and re-entry?
The good thing about Gaia wire is that it maintains the tip very well, unless you're knuckling or you're damaging the tip by pushing hard, then it gets damaged. Otherwise, it's a great wire. So a lot of the time, I tend to do this way. In that case, I couldn't spin the corsair. Ideally, what I would have done here was this. You're right here. What I would have done was spin the corsair all the way, or spin the corsair all the way to here, and then taken a fielder FC or some more slippery wire to enter the guide. But because I couldn't spin the corsair, because the lesion was very calcific here, so I just went with the Gaia 3. I was probably a bit lucky here. But you're right. I think Gaia 3 is not the best wire to enter the antigrade guide or a guideliner. The fielder FC is the best wire. For me, fielder FC works very well. And some people use Gladius. It's also a nice wire. But I always use fielder FC.
Okay, thank you.
So anyway, that case was finished that way. And then the conventional reverse card. So what is conventional reverse card? So if I'm taking you from the hybrid to conventional. So in the hybrid, what you do is you knuckle antigrade, knuckle retrograde, take a balloon, connect the two spaces, take a guideliner, and enter the antigrade guideliner. That's what you do in a hybrid CTO PCI. In conventional reverse card, essentially what you're doing is you're not knuckling. You're just basically bringing the wire so close, you only need a 2 millimeter or 2.5 millimeter balloon to connect it, because you're not knuckling. You're basically bringing the Gaia 3 or whatever the wire antigradely, and second wire, they're so close to each other that you just need a small balloon to connect them. In that way, you're not distorting the vessel anatomy. So for example, this case, RCA CTO, we tried to enter antigradely, failed, then came back retrogradely, and you could see the picture here. Can you see how close the wire are here? So that's the antigrade retrograde wire, and that's the antigrade. We're not knuckled anyone. And you see here, this is a nice picture. Can you see these wires are so close?
Yeah.
So in fact, you can't even make out there are two wires here, because they're literally on top of each other. They're so close. All we needed to was, can you see that's the guideliner there? That's the guideliner.
Yeah.
And I'm literally taking a small wire, we think probably a fielder FC or something, and just entered the antigrade guide here. So because they're so close, you need just a 2 millimeter or 2.5 millimeter balloon to connect them. And we finished this case with a nice, again, look, the vessel doesn't look too bad. It doesn't look too massive. The architecture is maintained. And this is another case of a conventional reverse card. So again, very blunt occlusion proximally. We have epicardial collaterals. Tried to do, kept going subintimal, came back retrogradely through one of these epicardial collaterals. And you could see the second picture here. Can you see how close the wires are? So that's the antigrade corsair, and that's your retrograde wire on a corsair. They're literally very close. And all we had to do was ballooning, and there's a guideliner, and then this goes into the antigrade guide system. And then we were able to finish this case. A lot of the time, the distal vessel looks like this, but they all perk up once you give some time, which is why we don't tend to treat this distally after opening a CTO. So look, I have shown you some very nice cases of a Japanese way of doing it. It works great, but there are cases we have failed in the Japanese way. So for example, this was an RCA CTO, heavily calcified, and had an excellent collateral from the vein graft, which was feeding one of the diagonal vessels. And in this case, we tried this Antigrade wire escalation Japanese way. We were tracking the calcium, but it's too calcified. I mean, we couldn't make any negotiation with the wire or the Corsair. So we decided to knuckle. So this came back retrogradely, and then basically knuckled the wire. And here we did something called a Carlino technique. So essentially the Corsair was not going. So essentially I injected a dye through the Corsair and disrupted this part. And then I was able to, you could see there's a knuckle. Can you see the knuckle there? And there's knuckle.
Yep.
And then I'm sure you've seen all these kind of cases in the meetings. So I'm not going to show much of these ones because they're the hybrid approach. And in the end, we were able to connect the two. So that's the final case of this one. Now, I would like to end with this last case, which is called the true case of best of both worlds. Okay, there's a history behind this patient. Oh, sorry, not this one. Yeah. So this patient, very unfortunate. So this chap is now in his 70s, but when he had his angiogram in 2008 or 9, he was only in his 60s or late 50s. He had a tight lesion in the LAD, tight lesion in the RCA, and tight lesion in the circumflex. Essentially a triple vessel disease. None of them were blocked. All they were narrowed. For some reason at the time he was managed medically. I still don't understand till today why. He was managed medically. Then they found out he had LV dysfunction. They put an ICG, which you can see here, and decided to just treat him medically. Now, exactly 10 years later, in 2018, he came to see me. He was extremely symptomatic. He couldn't walk 50 yards without having angina. And more importantly, he was having shocks from his ICD because he was having a lot of VT. So we decided to redo the angiogram to find out everything's blocked now. So LAD, which had some tight stenosis, is completely blocked. You can see here. And RCA blocked, circumflex blocked. So essentially, it's got all the blocked vessels. And no wonder why he was having sort of angina. Now, this case is a very good case because which one are you going to go for first? Whether you're going for RCA or the LAD. RCA has got no collaterals, or whatever the collaterals are probably coming from some small septal branches here and the distal LAD. But to access a distal LAD, you would open the LAD. And to open the LAD, you got no option of retrograde here because the collaterals you're getting LAD are from these tiny diagonals and things. And the only way to open that LAD is an antigrade approach. Now, if you go with this hybrid algorithm, I think probably they will do ADR here or a knuckle. And the risk of ADR is that you're going to lose this branch, you're going to lose this branch, you're going to lose this branch. All you'll be left with an LAD. Fine, I think you can do it. It's not end of the world. You can still do it. You sacrifice these branches, still the LAD will be open. Then you can use that as a retrograde channel for the RCA. So what I did in this case was we went with the conventional CTO approach for this. So that's the Gaia 3 and a Corsair. And what will happen next? Anyone, any guess where the wire goes? So Gaia 3 I've taken. Any guess where this wire will go? Oh, can you hear me?
Yeah, we think it'll go subintimal. Can you hear us?
Oh, you're going subintimal. Okay, so you're right. That's what will happen. But I was lucky in a way. It went into diagonal. Diagonal branch, and that's in a true lumen of a diagonal. So what I did was I used that wire, and I put a Sasuke on that wire, and then used the Sasuke, the other lumen of the Sasuke, to puncture the cap with I think that was the Confianza. And as you expect, I went subintimal because it's all calcium. Okay. Then using that as a landmark, I take another wire. You could see the wire. So the first wire down here now is the probably maybe it's guy 3 now. I've changed to guy 3. So that's guy 3, which completely subintimal. The vessel is here. Then I've taken another wire and trying to go out into the vessel architecture. So it's like a classic case of a parallel wire approach. Then I come into the vessel architecture. So I'm good so far. And then I push and I am kind of close. I check in the other view. I am close, although not fully into the lumen. I check in the lateral view. See, this is a nice case. Can you see? So here, I check 3 views here. Okay, so this is the first view, which is the RAO cranial, where a lot of people will say, why don't you push it, it'll go. Okay. And then here also say, okay, look, you are close, so you just need to push the wire. But then if you look at the lateral, I am way down. So if I push, all it'll go is it'll go subintimal again. So we redirected the wire using that lateral view, checked again in 3 angles, and I think that's another parallel wire coming in. And we got that one there, and then finally we are in the lumen distally. Confirm with the Corsair. We opened the LEDs. So it's amazing. So he came back for RCA CTO. So this was the LED. Now RCA, blunt occlusion. Okay. Very briefly tried antigradely. I knew that I'm not going to go much far in this. So I decided to go retrograde. So I used your very nice CO03 wire with the Corsair. Distal LED collateral. So collateral from the epicardial collateral. Came. Okay. Used this Gaia 3. Like usual Japanese way, but I was getting stuck. I was neither the Gaia 3 was moving nor the Corsair because it was so calcified. So I decided to go the hybrid. So essentially I knuckled. It's amazing because I used a pilot here, but pilot didn't work. Guess what worked? Any guess?
Gladius?
So Gladius was the one which worked. I think from my experience so far, Gladius has got more meat in it than the Pilot 200. So I think we are using, so in fact, I've used 3 cases of knuckling in Gladius in the last 6 months. They worked really well. So that's a Gladius knuckle. For the knuckle, that's to track the Corsair, more knuckling. And then we knuckle more. So in fact, guys, in this case, I had to use 3 Gladius because every time I made some progress, the